All right, so chapter 7 deals with the axial skeletal system, and the first thing that the chapter does is it makes the comparison of the axial skeleton and the appendicular skeleton. But the first thing that the PowerPoint does is it talks about the axial skeleton and how it relates with homeostasis. The bones of the axial skeleton contribute to homeostasis by protecting many of the body's organs. The cranium surrounds the brain, the vertebrae surround the spinal cord, and the ribs surround the heart and lungs. Bones also support the storage and release of calcium, which is an important ion that we talked about last week. This is coming from page 203, table 7.1 at the bottom of 203. The human skeleton consists of 206 named bones grouped in two principal divisions. The axial skeleton includes the skull bones, auditory, ossicles, hyoid bone, ribs, sternum, vertebrae, and sacrum. Appendicular skeleton includes 126 bones, bones of the upper and lower extremities, and the bones forming the girdles that connect the limbs to the axial skeleton. And we can see this nice diagram here. We should say this nice table. So you can see there on the left-hand side highlighted in blue is the axial skeleton, and the right-hand side, the appendicular skeleton, is highlighted in blue. So next week we'll be talking in more detail about the appendicular skeleton, but tonight we'll cover it just very slightly with this table. And so what you should know about the total number of bones is that adult humans have 206 bones, and I know that there's a biblical thing that says that men have fewer bones than women. That's just not true. Men and women have an equal amount of bones. However, children and babies actually have more bones than an adult does, because as you grow and mature, some of your bones will fuse together as one, and we'll talk about that as the chapter progresses, because it does happen. Some of that does happen in the axial skeleton. On the left, we see structure. So the axial skeleton really only deals with 5 types of bones, or 5 areas of bones, I should say, and those are in boldface. But the skull, the hyoid, the auditory, ossicles, the vertebral column, the thorax, and the skull and the thorax can be broken down into a couple different divisions. And so there's a total of 80 bones in the axial skeleton. And then if we look over at the appendicular skeleton and see the bold face, there's fewer bold face, but all of the bold faces are divided up into different bones, and that gives us 126. So if we add 126 and 80, we come up with a total of 206 bones in the adult human body. And then this goes on page 204, figure 7.1. And it just kind of shows the divisions that it was talking about on the previous slide, but it shows them in a little bit more detail. And then, of course, today we're focused on the axial skeleton, so we're really going to get into that now. But you can see here that the skull is probably the most superior portion of the body, and that has a number of different bones in it. You can just go through here and see all the different parts of the appendicular skeleton and the axial skeleton. So types of bones, this is another important thing, and this will also include a little bit of talk about the appendicular portion of the skeleton, but almost all bones are classified into 5 main types based on their shape. This is figure 7.2 on page 205. Short bones, and short bones are usually cube-shaped, and we find those in the wrist and also in the ankles. Flat, so flat bones are common in the skull for sure, and then also, as the figure shows, the flat bone, the sternum is a flat bone, and so the sternum is just the breastplate. The ribs do attach to it, but they attach to it through cartilage. You can see here, well, there's at least a couple of ribs that are not attached to the sternum. And then we have the irregular bones, or sometimes I like to call these asymmetrical. So the vertebra right here is a great example of that. And the sesamoid, that's because they're shaped like a seed. So the kneecap is a sesamoid bone, and There's also some sesamoids in your palms and in your feet. And they're very small bones, and what happens is that they're inside of some cartilage, and it helps to give your hands and your feet a little bit more rigidity but flexibility. And those ones in your hands and feet are very small. Well, that's another thing that I wanted to point out in tonight's lecture. Even though we say that there's 206 bones in the adult human body, actually these sesamoid bones in your hands and your feet, there could actually be more, because every person has a different amount of those in their body. So somebody might have more, somebody might have less. I guess there could be more or less, not less, but more than 206 in some cases. But for our practical purposes of this class, if I was to ask you on a quiz or an exam how many bones are in the human body, your answer would be, adult human body, your answer would be 206. This one talks about sutural bones and sutures. So what happens is that in the skull you've got these sutures, and a suture is really just a place where two bones in the skull are joining together. And the idea of a sutural bone is that as you age, these sutures are actually, they start out as cartilage, as we'll learn later in tonight's lecture, fontanelles, but it's a type of cartilage. So when you're a baby and when you're a child, this cartilage in between your sutures starts to calcify and become bone. And that's one of the ways that as you grow from your infancy to your adulthood, that's how the skull is able to grow. As an adult, your skull is going to be bigger than it would be when you're a baby. So that growth is allowed by these sutures that ultimately they calcify, and then they form essentially a bone in between the two bones. So we see here we've got the frontal bones and these two parietal bones. And then the suture here, the coronal suture, as you mature, this is going to also become a bone. This is 7.3 on page 205. So surface markings of bones. Bones have characteristic surface markings, structural features adapted for specific functions. There are two major types of surface markings: depressions and openings. They allow the passage of soft tissue and they help to form joints. And then processes, which are projections or outgrowths that form joints, and they also serve as attachment points for ligaments and tendons. This is coming off of table 7.2 on page 206. But you can see here it talks about depressions and openings, sites allowing the passage of soft tissue or the formation of joints. You can go through these on your own, but I'll just scroll through them real quick. You've got the fissure, so that's the marking, and then that's going to be like a narrow slit between adjacent parts of bones through which blood vessels or nerves can pass. And then an example of that is the superior orbital fissure of the sphenoid bone. So that particular fissure, then you would know, or you should know by the end of this class, not just because I'm telling you, but after you study the chapter, that this sphenoid bone and this orbital fissure is in the skull. So I'm not going to go through all these in detail, but I wanted to talk about this one because so you can get an idea of how to read through it. But other bone markings that you should be familiar with are the foramen, the fossa, the sulcus, and the meatus. And then we come to processes. So processes are projections or outgrowths of bones that form joints or attachment points for connective tissues such as ligaments and tendons. The condyle process, and that's a large round protuberance with a smooth articular surface at the end of bone, and the lateral condyle of the femur. So again, that's just to show you how to read through this and to study it, but we'll go through them just kind of cursory. A couple other types of processes are the facet and the head. And then we also have one process that forms the attachment points for connective tissue. It's called a crest. And then we've got the epicondyle, the line, the spinous process, the trochiner, the tubercle, and the tuberosity. So this is the fissure that we were talking about. So now the book's going to go through some examples of that. And I was having a hard time with this PowerPoint because it doesn't exactly go along with the book. I don't think there's a figure of this particular slide in the book, so have to refer to your PowerPoint for this close-up. So here's the fissure that I described to you earlier when we first started talking about the surface markings. So here's an example of a foramen. So this is where the spinal cord and the skull are going to meet. The fossa, so this is just a shallow depression, and you can see this. Now remember what we're looking at here. This is the inferior surface of the skull. And now we've got the sulcus and the meatus. So meatus is just a tube-like opening, so this is where your ear would be. It's not showing us a sulcus. So here's your condyle that we talked about. This is just a projection with a smooth articular surface, and you can see that here. And this is the inferior part of the skull. And then a facet, so this is a vertebrae. And then here's an articular facet right here. And so this is superior, so this would be the top of the vertebrae. Smooth, flat, slightly concave articular surface. And so I've used the word articular a few times now. What we mean when we're talking about the skeletal system and we talk about something being articular, that means that it will make contact or join to another bone. If bones are articulating, then they're joining together. This is going to be a part of the bone that's probably on the spinal cord. Well, there's going to be like the discs in between the vertebrae, but that is where it articulates with the discs. So that means that it's touching or coming into contact with something. So when we see articular, we know that that part of the bone is contacting another part, whether it's another bone or like it's a disc or a tendon or something. So here's an example of a head. This is usually a rounded articular process supported on a neck. And I believe what we're looking at right here is a rib. So this is going to have a head. And I would say that, I know we're talking about axial tonight, but I'm sure that we could call the ends of the long bone would be a type of head as well. So here's a crest, and this is like the sacral portion of your spinal cord. So this is the bottom of the spine. So this is a very irregular shaped bone. So we would also call this irregular. But we can see that this irregular bone has some very interesting features, doesn't it? And the main reason we're showing it here under surface markings is because it has this crest. And then it has a second crest here. And this crest is going to be a lateral to the, that's what it's called, lateral sacral crest. But it's lateral to the median crest. And there will be two of those. So there's also another one right here. The epicondyle is usually a rough projection on a condyle. So it's showing these lines. It's just a narrow ridge, and it's sometimes in anatomy, when you're dealing with the body on this level, is this a line or a crest? When I took anatomy, it was always a judgment call, but your book is telling you that there's a line right here, but it looks very much like a crest, doesn't it? So it would be easy to confuse with the crest. And even here, I mean, see how you've got this indentation here and another indentation here. Is this a crest or is it a line? They're calling this a line, and that looks, that one here, I mean, this, for one thing, this bone is going to be bigger than that sacral that we were looking at. So, I mean, you could call that one a line too. So all I'm saying is there's a fine line, and whatever we do on the quiz or an exam, I would go by what the book says. The difference between a line and a crest is a little bit gray to me, maybe not so much to a medical doctor. So here's the spinous process, and this is just a sharp, slender projection. So these here are how the spinal cord articulates, and we'll see that as the lecture progresses. The trochanter is a very large projection found only in the femur. And then here's a tubercle, a variably sized rounded projection. Here's the tubercle of a rib right here. So we can see here that we've got a vertebrae and how the rib is articulating with the vertebrae. And then it has this, what we call a tubercle, which is just this rounded projection. Tuberosity. So a variably sized projection with rough, bumpy surface. So that would be this part right here, and that's also going to be lateral to this crest. So now we're going to start looking a little bit more closely at the skull. The skull contains 22 bones, not including the 3 middle ear bones in both ears. So actually they're in your head or in your skull. You have 6 bones that are associated with the ear. Associated with these bones are a number of processes, rigids, lines, depressions, and foramina. What I wanted to say is that where the ear bones, there's 3 bones in each ear, so for a total of 6. And those 6 bones are not considered to be part of the axial skeleton, even though tonight we're going to kind of group them in with the axial skeleton. But I can tell you this about the ear bones. They are the smallest bones in the body, and they are the most dense bones in the body. So that was what I always thought was interesting about those. This is page 208, figure 7.3. So this goes through the various bones of the skull, and we see here we are looking at an anterior view of the skull. So you can see here the mandible, and now it's talking about the alveolar process of the mandible. So you can see all of these processes that are associated here. Yeah, here's the foramen, so the vomer, and the interior nasal concha bone, and the zygomatic bone. And so all of these bones here are frontal bone, this zygomatic bone, the maxilla, which is this yellow bone right here. And what's this small purple one? Lacrimal. Yeah, I knew that. So these guys are all articulating, among others, to make this thing that we call the orbit. And the orbit is just what we would, in layman's terms, we would call it an eye socket. So this is what's going to house your eyes. But you can see all the bones that come together and make up this orbit to house your eye. And then, of course, this part here is where the nose is, and we can see here the nasal bone. So this is maybe the part, if you wear glasses, your glasses may be sitting on your nasal bone. But the rest of your nose, this is cartilage. So most of your nose is actually cartilage. And then when it starts to get into the skull, articulating with the skull bones, then we get this nasal bone. So now if we look at the right view, lateral right view of the skull and the superior view, we can see some different bones here. So we see the parietal, so you got 2 parietal bones. And that was another thing I forgot to mention at the beginning, was that most bones in your body come in pairs. You have a left and a right. Not all of them, but many of them do. Like your lacrimal and the zygomatic bone. So those are all going to be in pairs. Now, that's doesn't really apply to your frontal bone. Your frontal bone is the only frontal bone. You don't have a left and a right. You just have one. But you can see all of the different bones that make up the skull. And then you can see the various sutures. So remember what a suture is. It's just a part where the skull bones are articulating to other skull bones. And this figure is on page 209, 7.4. So here we're going to look at a sagittal plane of a skull, and this is 7.5 on page 210. I'll point out this one real quick, because these are the 3 ear bones. So they're very small and dense, and you can see their names. So here we see the inside of the parietal bone. This chasm that this skull makes is where the brain is housed. So the skull's main function, well, not only support, I guess I can't say it's the main function, because support is definitely a function of the skull, but protection of the brain is one of the main functions of the skull. This gives us a nice cutaway, and we can see these various, so like the maxilla. So you see the maxilla here in yellow, and then you can see this yellow here. So that's also the maxilla. And you can just kind of see with this cutaway how the bones kind of look on the inside of the skull. So this is figure 7.6 on page 211. And this is just the posterior inferior view of the skull. So we're looking at the back and kind of like at the bottom. But you can see the sutural bones here, and of course here's our parietals again. The mastoid process, which is right here and here in the purple. Here's your maxilla here in the yellow. And then the mandible. So what I should point out now is that the mandible is the only bone of the skull that moves. All of your other skull bones are not movable. So that's an interesting thing about the mandible. But yeah, you can go through these figures, and also if you're working on your lab, you will go into these in great detail. So here's an inferior view of the skull. So see how the maxilla is kind of making up the hard palate of your mouth. And then you can see you've got your teeth here and zygomatic arch. You can see the parietal right here. And then, of course, our mastoids again. I should say mastoid processes. All the bones of the skull. And this view is 7.7 on page 212. And here's figure 7.8 on page 213. So this is an anterior view of the skull, and we've taken a transverse plane out of it. So we've cut the skull kind of in half, and we're looking down into it. And we can see all of the fissures in here and all of the different shapes that it makes to house your brain. And then here's the superior view. We're taking a coronal plane now of the skull. And we've got this sphenoid bone. So this is a very irregularly shaped bone. And you can see the sphenoid right here. The ethmoid bone is a delicate bone located in the anterior part of the cranial base, medial to the orbits, and it is sponge-like in appearance. So now we're looking again at the sagittal plane and having a close-up of this ethmoid bone. And this is on page 214, figure 7.9. And here we have it again, kind of in greater detail. And you can see this is another very irregularly shaped bone. Many irregularly shaped bones in the skull. Temporomandibular joint dysfunction is on page 217, down there at the bottom right. So it's just a dull pain around the ear. It gives you tender jaw muscles, a clicking noise when opening or closing the mouth, caused by improperly aligned teeth, grinding of teeth, trauma to the head, arthritis, etc. Treatment includes moist heat or ice, soft foods, and pain relievers. Another clinical connection. This one is on page 218, kind of there in the center on the right-hand column. The deviated nasal septum occurs when the septum does not run along the midline of the nasal cavity. This is caused by trauma to the nose or developmental abnormality. So this might be something a boxer might have if you've ever known a boxer and they get their nose broke. This could cause this deviated nasal septum. This can lead to infection, inflammation, congestion, headache, or nosebleeds. And it may require surgery to fix. And this is actually here on page 219, figure 7.12. At least the left-hand side is. And then the right-hand side of this slide here is page 208, figure 7.3. So we've already kind of talked about both of these. So if you would just give those a study when you read the chapter, and you should be good to go on that. So now we're going to talk more about the facial bones. And as I said, this is kind of 7.3 back here on page 208. this figure right here. So we're looking at the anterior view of the skull. And so the anterior view is your face. So you can see all of the bones of the face in this slide. Now we'll talk a little bit about the mandible. And this figure is 7.10 on page 217. The mandible is the largest and strongest bone of the face. Other than the middle ear bones, it is the only movable skull bone. Auditory isosceles, they move in the respect that when I hear a sound, they vibrate and they react to sound that way. So that's how they move in response to the environment. I don't know, I guess maybe you could call them involuntary because they're going to capture that sound. That sound is going to vibrate them. You're going to hear it. It's going to send signals to your nervous system, to your brain, so you know how to react to that sound. On the other hand, this mandible is voluntary. I'm moving my mandible because I'm thinking, move mandible. Or when I talk, I know it's happening quick because maybe I'm talking a little fast, trying to pace myself here so I'm more clear and articulate. But as I sit here and speak, my mandible is moving. Maybe not as much as if I was going to bite an apple, but it does move a little bit. So that's a good quiz or exam question for sure. Let's see the cranial bones and their other components, the nasal septum. So here we're looking at figure 7.11 on page 218. Most of these figures, they're just showing you the names and the locations of all these bones. So it's up to you to go in there and to read about them and to memorize them the best that you can. And with this lab that we're doing now, this is going to help you quite a bit because I was going through it this morning and it's very good. I'm really excited about the lab. But you can see here that the nasal septum, we got a little sagittal plane. And notice that the plane is not going all the way through the skull, so we're only getting a portion of that, like this square right here. So you can see here is like the maxilla and the palatine process of the maxilla. So the maxilla in every slide we've had has been in yellow. So I'm sure all these bones are color-coded, like they go from one slide or one figure to the next, and the maxilla is always yellow, etc. But here it gives you a better view of the vomer and the septal nasal cartilage. Part of what happens here with this sphenoid bone is that it's going to help you to resonate. It helps give a quality of tone to your voice. So have you ever heard somebody say, like, maybe about a singer, that their vocals are very nasal? As you can talk more, you can use your trying to do it consciously now. Or what is it? So here's my speaking voice, right? But and I want to talk through my nasal. You see how my voice changes? Also, if you have a cold, maybe you've noticed that if you have a cold that your voice changes a little bit, and that's partially due to the buildup of mucus that's blocking the airways. So it's giving your voice a different timbre than it would normally have if your throat and your nasal passages were clear. Figure 7.12. So this is like the third time we've seen this figure now, so I'm not going to spend time on it right now. But again, you can kind of see it in a little bit more detail. And this figure is on page 219. So here we're looking at table 7.3 on page 220. So I'll let you go through this table on your own, but these are the cranial bones and the principal foramina of the skull. So you can see each of the foramen canals of the skull, their location, and what is passing through said foramen. Sutures. So this is a unique feature of the skull. A suture is an immovable joint. It's found in the skull holding bones such as the temporal and the parietal together. So here's some names of some sutures: the coronal, the sagittal, the lambdoid, and the squamous suture. These sutures, coronal, sagittal, lambdoid, and squamous, I guess those are the ones the book wants. There's many more of them, but these are the ones the book wants you to focus on. And these are at the bottom of page 220 in boldface. So this would be something good to study. Here we have the unique features of the skull. So the paranasal sinuses, again at the bottom of page 220, paranasal sinuses, mucous membrane lined cavities, and the frontal, maxillary, sphenoid, and ethmoid bones. As I just said a few minutes ago, they're like a resonating chamber. They enhance your voice. And then also what they do is they increase the surface area of the nasal mucosa and help to moisten it as well. So it helps to give your olfactory, your nose, a little bit more surface area. Remember what happens, this nose is connecting you with the environment, because I can take in air from the environment and I can inhale and exhale through it. It has some surface area in there because there's mucus that builds up, there's hairs, and all of those are your first line of defense to any airborne pathogen that you might breathe in. So those are going to help filter those out. And of course, your mucus is rich in, what is it, IgA. If you remember from cellular biology or immunology, IgA, IgG, IgM, there's some properties to your mucus that have the ability to help combat foreign invaders that you might inhale. And then, of course, they help to moisten, keep it moist in there. So keeping it moist, whether it's with water or saliva or mucus or whatever the case may be, is idea of lubricating and keeping things lubed up so they move easier and they work better. So here's an example of the paranasal sinuses. So remember we were talking about the sphenoid, and here's the maxillary sinus. So another thing that I guess I should say now is that when you see like the sphenoidal sinus, well, they do that on purpose. So the sphenoidal sinus is associated with the sphenoid, the ethmoidal cells of the ethmoidal labyrinth. So that's going to be related to the ethmoid bone. The frontal sinus, so that's going, notice it's in blue. So remember the frontal bone was in blue on our previous diagrams. So that's associated with the frontal bone. So easy way to remember things like that. I'm not saying that's 100% of the time, but many times if you're talking about the maxillary sinus, it's a good way to remember that that's associated with your maxillary bone. So here's another close-up of the paranasal sinuses. And I am actually lecturing from 7.13 on page 221 right now. But you can see all of the surface area in here in your nose. And we've already pointed out so many reasons why this is important. It's important for your voice. It's important for your immune system. It is, in many ways, one of your first lines of defense. And I'm not saying that the bone necessarily is, but the soft tissues that are going to attach to that bone and make up whatever is going on in here. So the bone is providing the structure for that part of your immune system to do its job. So yeah, so I mentioned fontanelles earlier in the lecture at the beginning, and this is page 222 on page 7.14. So these are the areas of a fetus or baby where unossified mesenchyme develops into dense connective tissue. They close up through the intramembranous ossification by 2 years of age. The sutures here, and you notice that, for instance, on the parietal bone and the frontal bone, they're not connected because they're separated by these fontanelles. So as you mature, these fontanelles are going to harden and they're going to help form the immovable joints between your skull bones. This is figure 7.15 on page 223. And this is the hyoid bone. So the hyoid bone is a unique bone because it doesn't articulate with another bone. And it supports the tongue and provides an attachment site for some of the muscles of the neck and the pharynx. So let's go into the spinal column now. So this starts at 7.9 on page 223. So the spinal column has some common names, the backbone or the spine, composed of 26 vertebrae divided into 5 regions, and it protects the spinal cord. So you can see the 5 regions. You've got the cervical, the thoracic, the lumbar, the sacrum, and the coccyx. These are those discs I was talking about several slides ago. So in between each one of these vertebrae is a disc that helps to cushion, to keep the bone off of bone. And you can see on the various divisions of the spinal cord that, like for instance, the cervical vertebrae has 7 vertebrae in it. The thoracic has 12, the lumbar has 5, the sacrum has 1, and the coccyx has 1. I'm lecturing from 224, 7.16 right now. So yeah, so what I should have said here was we're looking at an anterior view of the spine. And when we look at the anterior view of the spine, it looks straight, doesn't it? But when we go to a lateral view of the spine, we can actually see that it has curves here. So each of the curves is named whatever region of the spine is curved. So we've got our cervical curve, our thoracic curve, our lumbar curve, our sacral curve, and our coccyx, which I guess is curved a little bit. But I always liken the coccyx to a tailbone. It's not in your book, but I think evolutionarily speaking, this may be the remnant of a tail, and there is some evidence to back that up. We can see on the left-hand side of this slide that we have normal curves. We have a primary curve and a secondary curve. So when we're fetus or young, just conceived, still in the womb, you can see that the spinal has a single curve. But by the time you're born and you start to develop into an adult, you can see these various curves here. Now, one thing I'd like to say down here about the sacral curve and well, here's the sacral curve right here at number 4. They don't really call the coccyx a curve, even though to me it looks a little curved. But this is one place, this purple region, where as you grow up, these bones fuse together. So this is one of the reasons a fetus is going to have more bones than an adult, is because all of these bones at this point are separate. They're not one. And then as you develop, your sacrum is several bones, and as you develop, it turns into one bone. And same for the coccyx. So we've been talking about the intervertebral discs a little bit, and those are also pictured on the same figure, 7.16 on page 224, but they're located in between the bodies of the vertebrae, and from the second cervical down to the sacrum. They're composed of an outer ring of fibrocartilage and an inner soft nucleus with the layer of hyaline cartilage on the top and bottom of each disc. Their function is to absorb shock and separate the vertebrae from one another. So I know I've had some people that were close to me that had some back problems. They had some of their discs had over their lifetime became damaged or worn out or whatever, and they had bone on bone, and it's very painful. The people that I've known who have had that problem have said that it's very painful. And one of the things that they will do in that case is what they call a spinal fusion, where they take 2 of your vertebrae and they fuse them together. So what happens in that case is you're going to lose some of your ability to move. Imagine taking this number 1 and number 2 of your lumbar curve, or your lumbar portion of your spine, and fusing them together. So you're obviously going to lose some ability to move there. But the idea is that it's better to lose a little bit of movement than to have to struggle with that pain. We're actually looking at the bottom right of figure 7.16 on page 224. And then you can see the vertebral body and the annulus of the fibrous and vertebral disc. Yeah, so this disc just kind of separates your vertebra and gives it some cushioning, helps to support, absorb shock. The vertebrae from each region, in addition to containing common structures, have unique structures that help to identify which type they are. Okay, so this is page 226, 7.17. Yeah, I think that what they're showing us here is just a generalized view of some portion of the spinal column. And I do not think that this portion we're looking at is a part of the cervical spine. I think this is inferior to the cervical spine. But let's find out. Let's see if we go another slide here. Yeah, so here's a cervical spine. And so this is, I should say, the cervical vertebra. Yeah, see how again, considering this is to scale, but see how the discs look thicker to me. and I don't see the dens. See, whenever I look at the cervical, I always look for the dens, which is, we'll talk about that in a second. So the dens of the axis. So here's the superior part. So we're looking at the very top of the spinal column, 7 vertebrae in the cervical spine. And you notice that this one lacks the protuberance that we see here. So this is what we call C1. So each of the vertebrae are numbered from superior to inferior. So if I asked you on a quiz or an exam, is a C1 vertebrae superior to a C6, and that would be true. Now, if I asked you if an L1 is inferior to a T1, is that true or false? Well, let's find out. L1 is indeed inferior to T1. Okay, do you see how I'm getting this? So the thoracic part of the spine has number 1 disc going down to number 12. They are superior to the lumbar vertebrae. So yeah, that's one way you would figure that question out. What's important, this is what I like to point out here, look at these fissures. So this is actually where the spinal column meets the skull, and this is called the atlas. So C1, yeah, it says it right here. C1 is actually called the atlas, and where that comes from, I think it was Greek mythology. Atlas was the guy who was holding up the world. So Atlas is the vertebrae that holds up your skull. If you think of your skull as kind of analogous to the earth in this example I'm using. But that's where that comes from, is that the atlas is the top, the first vertebrae, the one that the skull rests on. And then this one, actually, the dens of this axis is part of the C2. Yeah, see the axis right here? So this is part of C2. And this actually articulates with the skull as well. If you shake your head no, that's an interaction of your skull and this axis here, or this dens of axis. So these are the important parts of the cervical vertebra. So you can see here cervical vertebra in its different anatomical positions. And again, this is a 7.18 on page 227, and it's continued on to page 228. The thoracic vertebra support the ribs and have structures for rib head and tubercle attachment. So you can see this on page 229, figure 7.19. So this deals with the ribs. So what this can tell you then is that your vital organs are going to be in this area. And then it just kind of shows the difference. It shows the thoracic vertebra in their anatomical positions in contrast to what we just saw of the cervical vertebra at figure 7.18. And this figure is also continued on to page 230. And now this brings us to the lumbar vertebra. So these are the strongest and largest of the vertebrae. No special structures that are specifically associated with these vertebrae. So I guess what it's saying is there's nothing special about these. They're just normal vertebrae, largest and strongest. I would say that's maybe special about them. So lumbar, oh yeah, page 231, figure 7.20. So they make up what we call the lower back. So oftentimes people who have their herniated discs or whatever, or they need a spinal fusion, usually it's going to happen in this region of the back because this has the most stress and strain. And that's why they always say lift with your legs, right? Because if you lift with that back, if you're picking up something heavy with your back, I guess you could say your anatomy book's heavy. So I would be better off to pick up this huge book by lifting with my leg rather than bending over and lifting it up with my back. That's all I'm trying to point out. Because if you can do that over your lifetime, or advise your patients or your loved ones to lift that way, that helps to take the strain off of the back, puts the strain onto other parts of the body that may be more suited for that, and hopefully then your patients or your loved ones won't need to have something like a spinal fusion. And then again, just goes into the anatomical positions of the lumbar vertebra, like it has on the other ones. So here's the comparison of the cervical, thoracic, and lumbar vertebra. So you can see their different shapes and sizes. What you can take away from this is that the inferior vertebra are larger than the superior vertebra. So the lumbars are the largest, the cervicals are the smallest. And this is on page 232, table 7.4. Okay, that's a continuation of that. So the sacrum and the coccyx, the triangular shaped sacrum, is part of the pelvic girdle and is composed of 5 vertebrae that fuse. That's what I was saying several slides ago about how when you're an infant, when you're a fetus, the sacrum and the coccyx, they have a lot of different bones, and as you get older and turn into an adult, those bones are going to fuse. So that's one of the reasons why children and babies have more bones than adults do. So the coccyx is much smaller than the sacrum, but it is also a triangular shape, and it's composed of 4 vertebrae that fuse. So I just said that. And I'll just repeat too, because I think it's cool that evolutionarily speaking, I believe that the coccyx is a remnant of a tailbone. So here you can see them, and this is figure 7.21 on page 232. So you can kind of see here how this is fused, but if this was a baby, you can kind of see the lines. This is a line versus a crest. Remember we talked about that earlier, but see how these vertebrae have been fused. If I looked at this, I would say, yes, this is a sacrum of either an adult or a mature teenager. As you're getting into your teens and your 20s, they should be pretty much fused. So now we're going to get into the thorax, and this is 7.11 on page 233, but thorax is really a generic term for the chest region. Oh, it says that right there. The thorax is the entire chest region. The bones that compose the thoracic cage are the sternum, the ribs, and the costal cartilages. So you can see those in greater detail on figure 7.22, which stretches from page 234 to 235. And then, so here's page 234. We're still on figure 7.22, but you can see the 3 segments of the sternum. So here's the superior, and here's the inferior. We've got the upper manubrium, and then we've got the middle body, and then this little xiphoid process, which is the smallest part of that. The sternum articulates with the clavicles and the costal cartilages. You have 12 pairs of ribs. They provide structure and support to the thoracic cavity. The first 7 pairs, their cartilage is directly connected to the sternum. Those are called true ribs. And then on the next 5 pairs, the cartilage is indirectly connected to the sternum, and those are what we call the false ribs. And then the floating ribs are the last 2 pairs, and they are not connected to the sternum. Page 235, figure 7.22. It actually shows, see 11 and 12. So these are the 4 ribs, or the 2 pairs of ribs that are not connected to the sternum. I just think that this figure shows it better. So and in your book, it's much bigger than this. So if you're looking at your book right now, you should be able to see it. But those are your floating ribs there. This 7.23, it starts on 235 and continues on to page 236. So you can see here the costal cartilage. We mentioned the head when we were talking about features of the bones early on in tonight's lecture. So you can see that, I would say, to me, the rib would also be another example of an asymmetrical or irregular bone. So then the book goes on to talk about some disorders associated with the axial skeletal system, and that would include herniated disc. So I already talked about that a little bit. People with herniated discs, if it gets so bad, it can lead to where they need a spinal fusion. But you can see that here's your disc, and it becomes herniated as it's starting to push on the spinal cord. And that's going to send signals to your brain that there's some pain. Hey, there's something wrong in my back. I need you to look at this. So that's why that's bad. And again, back pain is nothing to take lightly. So then it goes on to talk about some more disorders, curved related pathologies. So sometimes your spine can be curved in an unnatural way. And you can see this at 7.25 on page 238. A scoliosis is where, if I'm looking at it from the anterior or the posterior, the spine is curved like this. And you can see some examples of it. And then the kyphosis, which is where that's what we would call a hunchback, kyphosis. It could be genetic or it could be a product of your environment. And then we see the lordosis. And this often is common in women because it can happen during pregnancy, that can give you that lordosis. And also, I should point out here that I know a little bit about these because I've been around some bone stuff. Scoliosis is also another disorder, affects more women than men. So scoliosis, it often is not diagnosed until you're 9 or 10 years old. The way that you would diagnose it if you were a nurse or if you're an MD in the doctor's office, one way that you could diagnose that is that you stand posterior to your patient and you ask your patient to bend over. And when they bend over, you'll notice the line on the back. When they bend over, the line on the back is not straight. You'll see the line on the back curve as such. And you can see it there clearly on 725. Now, the person at 7.25 on page 238, she's got a pretty severe case of that. So I would say, again, it's hard to tell from the picture because I can't see her face or anything, but she looks like she could be a grown woman or at least a teenager. And so what I would hypothesize in her, or my idea, again, I'm not an MD, but I do know a little bit about it. I would say that that person was not lucky enough to be diagnosed when she was young. If you can catch this when your kid or your patient is young, that's when you got to do it. You can't really cure scoliosis, but there are treatments for it. There's some doctors around the country who offer exercise programs where they try to use like a counterbalance, and they'll have the patient balance on. It almost looks like the planet Saturn. It's got a ball with rings. And if you could imagine cutting that in half where you just got the rings and then the lower half of the ball, and then you would balance on that and you would have a counterweight, and they try to do some physical therapy with it. That's one way. If you can catch it early enough, especially before puberty or right around the onset of puberty, the idea is that you can train those muscles to grow differently than they're growing, and then that will take some of the curve out of it. And then in the worst case scenario is that you would need a spinal fusion. And I know I was talking about spinal fusion for, especially in the lumbar region, but even up in the thoracic or the cervical, it would be possible with this patient here that we see on figure 225, how her curve looks thoracic to me. Look how the shoulder blade looks. The lumbar is going to be down where that little fissure is right there in the center of the back. That's probably about the start of the lumbar. But if we look at where the curve is, you can see the curve is really in the thoracic, and it may be even going up the lower part of the cervical. In your spinal column, there's more movement in the lumbar region than there is in the thoracic. There's more movement in the thoracic than there is in the cervical. What you can do then is you can do another type of spinal fusion where you can take the rods and you can flank the spine with 2 titanium rods in, and then that's going to help take a certain percentage of that curve out. It might not take 100% of the curve out, but one of the problems with scoliosis is when you get that big of a curve, it's obviously pushing on her right lung, but if that is going the opposite way to the left-hand side, that can push on your lung and your heart. It causes all kinds of problems. So scoliosis is certainly nothing to take lightly. And now that you're a little more educated about it, if you have small children, particularly daughters, something to watch out for in them. And again, with scoliosis, it's not, at least not at this point in time, we don't really know if I'm sure there is some genetics involved in it, but there's no evidence there's no 100% scientific concrete evidence that it's 100% genetic condition. In other words, you could look at the family history and see, well, parents didn't have it, the grandparents didn't have it, did the great-grandparents have it? Well, who knows? Maybe they weren't even checking for it back then. And certainly if they didn't have any major problems with shortness of breath or dying young or whatever, then maybe they didn't have that problem. So where does it come from? Is it environment? Is it a mutation? I don't know. And I'm saying I don't know in the broad sense that I'm not sure at this point in time of our scientific knowledge that anybody knows what the underlying cause of scoliosis is. That's what I was talking about. See how she's curved. So her heart's going to be right about here, right? So this curve is obviously pushing against her right lung. And I'm saying that if this curve was going to the left here, she would probably have heart problems too. And to me, this is a pretty extreme case of it. Now, some kids are going to have this. Um, if I had to estimate, I would say this might even be a 50-degree curve. And there's certain degrees in the curve. So if you only have a 5-degree curve, I mean, that might not even be something that your doctor would worry about. But once your curve starts getting into the higher, like maybe 10 or 12 or 15 degrees, well, then you got to start taking this serious, and you got to start trying to figure out things to do to counteract that. Like I was saying, there's some physical therapy out there, and there are a few doctors out there around the country who can do that. This is just, so I was talking about all these, so you see the kind of how he's arched a little bit more than he should be here, and then you can see this person with this curve right here. Like I said, this one here, this is usually oftentimes caused by pregnancy. This one, still trying to figure out what it's caused by. And the kyphosis, this could be an example of maybe this particular person had bad posture when he was growing up. And the growth years, the prepubescent years, during puberty, those are times you got to be really conscious of some of this stuff, because your body's still growing and shaping, and if you can catch something like scoliosis in particular, I already told you how to identify it. Just stand posterior and have them bend over, and then that curve becomes more prominent. If they bend over and you've got a straight line there, you probably don't have to worry about scoliosis. If you're not a doctor, I would talk to your doctor about it. If you take your daughter to the doctor, or if you are in a doctor's office and you're a nurse and your doctor's not really looking for scoliosis in young children, well, maybe you could point that out to him. Look, it can happen to boys too. I'm not saying that it can't. I'm just saying it's more common in girls. So if you go to the doctor with your kid, asking, it doesn't hurt to ask. And statistically, it's very low occurrence, but it does happen in the world. So there you go. Spina bifida is a congenital defect of the vertebral column where the laminae do not develop normally. The degrees of this deformity are very minor to severe. And you can see a picture of it. Fractures, that's another, what your book is calling a disorder. Fracturing your back or breaking your back. If that spinal cord is damaged, that could be irreversible. I know people who have had back injuries who became paralyzed either from the waist down, or they become quadriplegic, I think is the word. That one movie star who played in the original Superman, Christopher Reeve, healthy guy, I guess a nice figure if you like that kind of stuff. He was riding horses and got thrown off his horse and broke his back, became a quadriplegic. It is true that if you break your back, there's a high probability that you could do some irreparable damage to your spinal cord, and that could result in paralysis, or at the very least you may get some nerve damage, which just may take some of the feeling out of certain parts of your body. Well, that's all I have for tonight's lecture.